you find somebody who has a marginal PSA, say in the 4 to 6 range, or maybe even a bit higher than that, and you find some firmness in their prostate with a DRE, do you feel that it's recommended at that time to do the 4K4 test just to see if there is a higher probability that that person is at greater risk than otherwise?
If I feel a firm, so if I am feeling the prostate and it feels firm, okay, so the old way of talking about that was clinical stage T2. So T1 is you don't feel anything, but you do a biopsy and you find cancer. T2 is where you feel half of one lobe of the prostate that feels firm. Just by virtue of having an abnormal digital rectal exam, we know that 30% of those can harbor prostate cancer. Okay? If they have a nodule, that kind of trumps everything. And at that point, I don't really care what the PSA shows, because if you have a nodule, it's almost like if you had a mass on your arm, the only way of really knowing what that mass is by removing it. You can look at it all day, you can draw the blood work, but if you have that mass, you should probably get it checked out. So the nodule is really the kicker for me there. If the patient did not have a firm prostate or a nodule, I'd want to look at what the PSAs were prior. And usually the first thing I'll look at there is kind of the cheap, easy test that doesn't take time to send out and bring back. It's just free PSA. So between PSAs of 4 and 10, I'll check a PSA and free PSA, which is a circulating, active sort of PSA in the blood. And it's an inverse relation to the PSA. So if you have a PSA of 6, but your free PSA is 8% or 5%, that translates to about a 56% risk of cancer. When you're between 10 and 15, I think the number is 28% risk of cancer. When it's between 16 and 20, it's like 16% risk. If it's over 25%, I think it's like an 8% or 10% risk of cancer. So I will usually use a free PSA there to figure out, could this possibly be more due to BPH or enlargement of the prostate, or more towards prostate cancer risk. So anytime I take the intake sort of questionnaire and I ask all the questions, I want to know, how's your urination? Have you had a history of prostatitis? Have you recently had sex? Have you had any instrumentation of the urinary tract recently, like a Foley catheter? Any urinary tract infection, any history of stones? Do you strain to have a bowel movement? Those sorts of things. Because anything that stimulates the prostate can potentially cause that number to be elevated, right? And so even, if I do recheck it, so if, let's say you had that PSA check 2 weeks ago, but the number before that, let's say it went from 5.5 to 6, okay, but you had never had a PSA, never had a prostate biopsy before, and then I do a prostate exam on you and everything feels fine, on paper, you would say, yeah, you need a biopsy. But for patients that say, I'm really not comfortable with just moving straight to a biopsy, that's when I'll do a free and total PSA at that visit to kind of get more information. Or if it's gone from 4 to 4.5 or something, I'll say, you know what, chances are with that 4.5, if there's no abnormal exam and no family history, and you don't have, the factors there would still put you in the low risk category. Sometimes, if it's very patient dependent, I'll say, let's recheck it in 3 or 6 months and just plot a line out. Especially if I only have one lab value. So if you just showed up in my office today and you had a PSA of 6, and that's all I have, you've never had any PSAs ever before, I would either check a free and total PSA, or I'd give it about 3 months and recheck the PSA. The reason being, now I have 2 points on a line and I can actually see what the growth is. And 3 months of time with a PSA of 6, generally speaking, is not enough time for your cancer to run haywire. Now, if your PSA was, 28, I'm not going to give you 3 months. At that point, I say, look, just by virtue of having a PSA over 20, you need a biopsy.
I asked that question because over the years, my PSA has always run okay. And I've had my PSA done for years. And I have a PSA of 1. okay, and I would always have a firmness, okay, with the DRE, and the doctor always said I wouldn't worry about it, okay, I mean, just, with the low PSA, my PSA stayed low, okay, for years like that, but there was always a little bit of firmness in there. It was only over the last 5 years, from the time I had an RP, okay, it went from 1 to about a 4.5 over about a 5-year period. It was only then when I asked for a biopsy, and but it was just very slow growing. But all that time, it seemed like I've always had a firmness.
Yeah, PSA is a good test. It's a cost-effective test. It's a cheap test. It's an easy test. It's got its flaws though, right? Just like any test. There's no smoking gun test where we can say you probably have prostate cancer or you don't. Now, of course, if your PSA is 1,000, it's clearly prostate cancer until proven otherwise. But we know that there's some super high-risk prostate cancers that do have a PSA of 1, 1.5. Now, I'm not saying that that's you, but the idea behind that is what we call PSA burnout. So it's where the cells are so mutated and so abnormal that they don't even produce PSA anymore. So that's where, and that's one thing that I try to stress to some of the primary care docs is that, there's this thing where it's like, don't do a prostate exam. Like, it doesn't really show anything. Fine, but when it does show something, you're only going to know if you did an exam, right? And what we're seeing ever since, and luckily our primary care docs here in town are great, and they're referring patients to us and all that, but if you're not doing that exam, that's part of the staging. That's part of the clinical staging. Doing a PSA and a prostate exam is actually part of risk stratification. When you look at like D'Amico criteria in terms of are you low risk, intermediate risk, high risk. If you look at the NCCN guidelines, one of the things that puts you in a risk, puts you in a certain risk profile is what do you have on prostate exam, So it's difficult to tell. So with you, so it could have been that, yeah, you had a nodule maybe from BPH or something. It could have been prostate cancer, but maybe it was something either low risk or benign, and then at some point, whether you had the nodule or not, now you're starting to produce more PSA quicker from presumably cancer cells, and that's what was caught. But that's a good point. In the future, that may be something, to get back to your point, maybe an MRI would be good for that. You have a nodule, but you're not quite ready to do the biopsy. See what the MRI shows, Now we're kind of, this is all hindsight, but.
Can I?
Yeah, sorry.
This trial at UC where they're doing MRIs, how do I find out about that?
There's a doctor, and I believe he's doing a trial on it. His name is Abhinav, A-B-H-I-N-A-V, Sidana, S-I-D-A-N-A. So he's one of the 2 urologic oncologists there, Bruce Bracken and Abhinav Sidana. Abhinav trained he was actually a year below me in residency. He trained at UC. Then he went over to, where'd he go?
Johns Hopkins.
NIH.
Sedana is still at UC.
Who's that?
Sedana is.
Yeah. So, but then he did a fellowship 2 years at NIH, and then got recruited back. So, if you're interested in clinical trials, he's a point man because he's the guy who's running some of those clinical, or at least they may be multi-institutional trials, but he's accruing some patients for that. And I don't want to tell you for sure. I know that for the most part, he's doing if I'm not mistaken, I think he's doing an MRI for most of his patients with elevated PSA, and I'm pretty sure he's doing that as part of a trial, but I can check on that. Yeah.
I'm curious about the mechanism of PSA. They've had it around for a long time, but like my father, I don't think they realized that there was such a thing as PSA in 1920 or 1940.
No, of course.
But I'm curious, what's the actual mechanism? To me, it always seemed that since it's called an antigen, that the body is reacting to the abnormality in your prostate. But from what you just said a moment ago, it sounded like there may be the possibility that the prostate is in fact producing the antigen. And I've always wondered if you take the right kind of medicine, could it just be suppressing or masking the PSA? Because you mentioned.
Well, that's an interesting sort of thing. So if we know that the more cells you have in the prostate, the more PSA it can produce.
So the prostate that actually produces the antigen,
PSA.
not the rest of your body attacking.
Right, which is why when you remove the prostate, your PSA should go down to 0. Because the only thing after your prostate's removed that should produce PSA is prostate cancer cells at that point. Right? I'm okay. I'm good. Yeah, thanks. Oh man, I'd have to dig back into molecular biology to give you a
But like I'm under
smart answer for that
therapy,
one.
for example, so my PSA has gone down to practically 0. They say it's
Less than
sensitive,
0.1, yeah.
But I was wondering, could it be just that the testosterone is wiping out the PSA that is being produced, or that really it's not being produced anymore?
Do you,
When I
so
say the
if you
testosterone-
don't mind me, I don't want to pry too much, but did you have your prostate removed, radiation? Did you-
No, nothing. I didn't realize that I had a problem until I started seeing blood in my urine, and my PSA had already spiked to 160.
Okay.
So they did the MRI.
Yeah.
It seemed like, to me, it was something that they did routinely. There was no
So
question.
you're on like TrellStar or Lupron or something like one
Yeah,
of the
and
androgen
then I got
antibodies?
the biopsy, and I'm Gleason 10, and then
Yeah.
they put me on Firmagon for 1 month, and then Lupron ever since.
Yeah, okay, good. Yeah, so the idea there is, the way I explain that, generally speaking, in kind of the office setting, is I say, prostate cancer cells need something to feed on to continue to survive and replicate and keep going. Testosterone is that fuel. You cut the testosterone, you cut the PSA. Because the prostate cancer cells that are expressing PSA can't express it anymore because those cells don't have the food that they need to continue to grow. That being said, we know that at some point, once you start hormone therapies, prostate cancer cells are going to overcome the ability that castration has of suppressing prostate cancer cells. The second you start Lupron or TrellStar or Firmagon or whatever, at some point, the PSA will start to rise again. Okay? And that's when you need the advanced prostate cancer drugs. The reason for that is because, and then you may wonder, well then why do you still give Lupron if you're going to get some of these advanced prostate cancer drugs? The reason and the idea behind that is that these androgen deprivation things, these LHRH agonists for advanced prostate cancer.
Switch it up so the prostate is...
Well, they're still working on a subset of the prostate cancer cells that are still working, that it's still working on, but then you need something else to get those other types, because we know that they can do sort of this mutation sort of thing as the cells are splitting. You know, they're kind of learning.
I kind of thought, like, if you get a mosquito bite or a tick bite and you get Zika or something like that, then your body produces an antigen to a foreign substance in you. But when it comes to the prostate, you're saying the prostate actually produces its own antigen.
I believe so, yes. Yeah. So it's specific to the prostate. I think, if I'm not mistaken, I think PSA can also be in like salivary glands or something, but in a much lower quantity. It's almost a negligible quantity, but I think that it's in prostate, and I think there may be PSA that is produced by salivary glands or something like that.
This may sound...
PSA.
This may sound a little bit naive, but the discussion seems to be rotating about whether to have a biopsy or not. And I was thinking about my situation. The MRI is really no muss, no fuss. You just have to lie still for a while, and it's loud. But but they did the biopsy then also, and it probably took about 3.5 hours. And you have to have an anesthesiologist, surgeon, a nurse. You're knocked out, but it's painless. And except for not being able to ride my bicycle for 2 weeks afterwards, it didn't seem to be that difficult. But it probably is a lot more labor intensive. Is there a more specific reason than cost effectiveness why you just wouldn't have a biopsy? Was I just lucky that there was no after effects or anything?
No, I mean, the biopsy, we try to make it as comfortable as possible. And so I guess your question is...
But isn't that the kind of gold standard then about
it is.
maybe have cancer?
Taking tissue is the only way to really know whether you have cancer or not. There are men that I have seen in my practice that are 80, 85 years old that come in with a rock hard prostate and a PSA of 1,000. And I'm a nice guy. And so I say, you don't need a biopsy, let's go ahead and start treating you. you have prostate, I can put you through this procedure and we can both pat ourselves on the back that we diagnosed something that we both already know is true, you know? And so in those situations, I have a guy that I saw today that had a PSA of 512, rock hard nodular prostate. I kind of put the cart before the horse a little bit, went ahead and did a CT scan, bone scan on him, metastatic disease in the bone, metastatic disease all through his retroperitoneal lymph nodes. I said, look, we don't need to necessarily put you through a biopsy at age, he's 86. I said, we don't need to necessarily put you through all that unless, for whatever reason, it becomes an insurance issue and they must have a biopsy-proven thing to treat you the right way. And they didn't ask, you know, Medicare didn't ask any questions, and we submitted the right clinical diagnosis as prostate cancer. And I'm giving him Lupron, and his PSA is down to 0 now. You know, I mean down to an undetectable level from 512. You know, so prostate biopsy is still the gold standard. You know, I mean, at some point we're going to get to a point where we can say an MRI can rule out prostate cancer. We're not there yet. You know, we're getting there. We are getting there, as I said earlier. We are getting there, and I would surmise that probably somewhere in the next 10 years or so, you know, we're going to see that. I mean, think about even 5-10 years ago, Gleason 6s. All of them were coming out. If you had a Gleason 6 prostate cancer, your prostate came out, right? And now, and you know, yeah, we can say, hey, look, we have an undetectable PSA for 7 or 10 years, but in a sense, some of that is self-fulfilling prophecy, right? And that's why they eliminated Gleason 2, 3, 4, and 5 for that very reason. That are they really prostate cancers if you can live 35 years without them ever causing any issues? It may just be more dysplasia or something as opposed to, or metaplasia as opposed to cancer, right? And yeah, 20 years ago, people were getting perineal prostatectomies, open prostatectomies for Gleason score of 5. And now we do have these trials that are coming out that are showing that radical prostatectomy compared to active surveillance up to even 18 years has an equal survival for particular patients, depending on their PSA. And of course, they're on active surveillance, so they're going through the protocols and have multiple biopsies and everything. But that's a huge deal, right? I mean,
I'm just curious though, because the discussion was like, should we or should we not have a biopsy? To me, it was kind of presented to me like, well, it's just the normal thing to do.
It is the normal thing to do, but you know, there are, meaning it is standard of care. But these days, when you have options or patients don't feel like they want to rush into a procedure or something, you know, now these days it's all about options and all of that. So we have to find some way to at least explain and understand and explain the data to, without being very forceful to say, you must have a biopsy. Now there are some patients where I say, forget about it, like that guy I told you about earlier, PSA 17, I said, look, I can get an MRI, I can get a 4K score, I can get, you know, PHI, get all these tests on you. But at the end of the day, you've got an abnormal exam and you have a PSA of 17. We don't want that gentleman to come back 3 months from now with a PSA of 50 and neglects it, and then 3 weeks, you know, 3 months later he comes back with a PSA of 100, etc. The goal here is to catch clinically significant prostate cancers earlier and deal with them early to prevent things.
I may step in here. I think the issue is if you have your PSA about 4 to 4.5 and your urologist is doing the biopsy, and then you're going to, let's say you do active surveillance and have a biopsy every year. So right now what I'm reading is that the chance of infection from biopsy keeps creeping up. And it's got to the 3%, 4%, some studies say 5%. If I have one every year, what are my odds of probability eventually I'm going to get some kind of a sepsis type infection?
Yeah, or a subtotal prostatectomy.
So why are you recommending a biopsy as a follow-up?
Okay.
When today we do have MRI, which catches most clinically significant prostate
Very good
cancer.
question. Very good question. Very good question. Very important question. There was data that came out last year, I believe it was last year or the year before, I think out of Johns Hopkins, if I'm not mistaken, that basically was trying to look at, and it was published in the Journal of Urology, that was trying to look at active surveillance protocols and whether we're doing too many darn biopsies. And what they found is, yes, between 6 and 12 months after your initial biopsy, if you're on active surveillance, you should have another biopsy, that first time, okay? And you can do that either MRI biopsy, or you can just have another 12-core saturation biopsy, which is 24 cores, whatever it is. But after that, if you don't have any increase in prostate cancer, so you're still Gleason 6, PSA hasn't moved much from 4 to 4.5, the sweet spot is actually about 3 to 4 years. That you can space your biopsy out to 3 to 4 years without compromising cancer outcome.
Without any other intervention, no MRI or anything?
No, just checking PSAs regularly and a prostate exam. So the idea there is that you're not over biopsying. Now this I believe was retrospective data. Okay, so we have to keep that in mind, that it's not taking two guys and following them going forward, one in this arm, one in that arm. It's looking back at the biopsies that were done, because the fact of the matter is, before it was a thing, there were still some urologists that said, there were like-minded people that said, man, you've had a biopsy 3 times in 3 years, let's just give it, it was probably patient-driven. Patients were like, I don't want a biopsy next year. So they said, okay, well, we'll just check your PSAs, let's give it a couple years, and let's see. And what they found when they looked back at this data was that prostate cancer didn't worsen. Or at worst, if you did it at 3 or 4 years in a low-risk or very low-risk patient, they may have gone from a Gleason 6 to a 7, which is still totally curable. It wasn't like it went from a Gleason 6 to a Gleason 9. Okay? But you're right. So, if you, and again, I don't know your whole history, but let's just say that you've been on active surveillance and you got a biopsy and a biopsy next year and a biopsy the next year, and nothing has changed. There may be even times where they biopsy you and you don't even have prostate cancer. Meaning, on this, we know you have it, but on the specimen, on the follow-up, because it's such a small area that you don't have it, that would be one of those situations where you're using your PSA, your exam, plus or minus an MRI to figure out when you need your next biopsy. But probably if you've had it for several years and the PSA has been very similar and your prostate biopsy results have still been Gleason 6, chances are you probably don't need a biopsy for another 2 to 3 years, at minimum. But the data set, the sweet spot there is about 3 to 4 years. So I hope that answered your question. That's new data. That's last year, and again, the caveat there is it is retrospective data. I don't want you to tell your urologist that, and then 4 years later you get a biopsy and it's Gleason 8. I'm not going to sleep well at night if that happens. But the data is pretty strong retrospectively about that. I mean, this wasn't like 10 or 15 patients. I mean, this was hundreds of patients that they looked back at. So,
yes, pretty good. Yes. Speaking of statistics, did I understand that you were saying somebody who's had a prostatectomy ended up down at a PSA 0? You expect it to start to elevate again after?
Not always, not always. So it all depends on particular factors before surgery and after surgery. So the before surgery factors are, what was the PSA, what was the prostate exam like, was it very firm, and what was the preoperative Gleason score. The postoperative factors that are predictive are, did you get it all out, right, where the margin's negative, margin status. Did it go outside of the prostate? Did you have extra prostatic extension? Did you have seminal vesicle involvement? Okay. And lymph nodes is kind of a different thing, but those are really the 3 main things. And last but not least, what was the final pathology? If you had your prostate removed for Gleason 3 plus 4, was the final pathology 4 plus 3? Was it 4 plus 4? Was it 3 plus 4? Or, 3 plus 3 or something like that. So that plays a role. And then the added thing to that is some of the genetics behind it, which is an independent prognostic indicator, like the Decipher test or the Oncotype DX or Polaris. And we're actually doing the Decipher test now as a reflex after patients that have had a biopsy that are either Gleason 6 or 7, because They won't pay if it's 8, 9, or 10 in a pre, because you kind of know what you need to do. You need to stage them and all that.
Say that last part again, louder.
We are now doing something that Jen is actually running the show for right now, which is fantastic, and it helps the doctors out tremendously. That we are sending that genetic test called the Decipher test after biopsies that show prostate cancer that's either Gleason 6 or 7. The company and the NCCN guidelines they do not think that it necessarily needs to be done for Gleason scores of 8, 9, or 10, because those are already high-risk prostate cancers, and prostate cancers that you're already going to do a CT scan and a bone scan and stuff like that for. So they're just, insurance companies aren't paying for it for the higher risk ones, although Prolaris is another test that they'll do it on any Gleason score at all. But again, any test we order is with the presumption we're going to do something with that information that's going to affect our treatment. So we're sending the Decipher test for patients that have Gleason 6s or 7s, because those are the ones that it's either going to be active surveillance or surgery or radiation or whatever. And similarly, after your prostatectomy, if you did have a positive margin, if you did have seminal vesicle involvement, if you did have extra prostatic extension, you're getting that sent out after surgery if you didn't already get it sent out before surgery, or after your biopsy. Because that's going to give you 3 pieces of information in that test. And you wanted me to talk about that a little bit earlier?
From what you were just saying, it sounds like what they're doing is just gathering data at the stage to develop correlations.
No, this has prognostic information. So
based on correlations they're developing, right?
What do you mean by that?
Well, if they're looking at gene in other words, what do the genes look like compared to the cancer that they have, and then they can use that for
right. So they're looking at different mutations, and some of them are looking at homeobox genes, some are looking at other sorts of genes. But the bottom line behind that testing is the more data points you have, the more meaningful information you have to collect prospectively. So, if we check this test 5 years ago and we check this test now on the same person, it may be a little bit different because we have more data sets, more data points. So it gives us 3 pieces of information. It gives us what is the likelihood that you have in the post-biopsy pre-surgery setting. What is the chance you have Gleason 4 or 5 pattern in your prostate? Okay. What is your 5-year metastatic risk? Hugely important prognostic indicator. And last but not least, what is your 10-year survival? Okay, Prolaris does the same thing. They give you some of that information, but in the post-prostatectomy setting, the most important thing there, if you have a positive margin or T3B disease, seminal vesicle or extraprostatic extension, is we want to figure out whether this patient is going to need early radiation or not, right? Can we sit on it until there's a PSA rise, or is that positive margin concerning enough to where we think we need to go ahead and radiate to prevent complications down the line, okay? So that's where they give you information of the 5-year metastatic risk and 10-year mortality data, which is extremely important. If he had his prostate removed, and I'm just throwing this out there hypothetically, with a Gleason 7 of a PSA of 11, and we get that, but I had a little positive margin, okay? So it didn't go out of the prostate, it didn't go to the seminal vesicles, but there's a little bit of a margin there that had prostate cancer. So that does not necessarily mean that prostate cancer has gone, that there's prostate cancer left behind. It just means it went to the cell layer that was removed. So if we did a Decipher test on you for that particular reason with a positive margin, and let's just say that the 5-year metastatic risk was 28%, because I've seen that before, right? Everything else, it didn't go anywhere, the lymph nodes were negative, but you had a positive margin of 28%, and you're a 50-year-old guy, at least I can counsel you, even if we don't immediately do radiation, I can counsel you that, hey, we're going to have to really keep an eye on this every 3 months for the first couple of years, PSAs, and then every 6 months, and then every year, because the second we see a rise in that PSA, we know what the genetics of that prostate cancer are. We should go ahead and bombard it with radiation and put you back in remission, put you in cure. Whereas if a patient had you know, let's say seminal vesicle involvement and Gleason 7 on their final thing, but negative margins and everything, but the Decipher test showed a 2% risk of, and again, it's not a be-all end-all, you have to kind of take everything together. We never just go by one thing. And it showed there's a 2% 5-year risk of metastatic disease. That may be a guy I hold the horses on. I'm not rushing into any sort of radiation or stuff like that. I'm still going to follow him, but it guides future therapy, not immediately the then and there. Okay?
When you said there's 2 major companies involved here, and one of them, they wouldn't even bother to collect 8, 9, or 10 Gleason scores, it's just not worth it. The other company, they'll collect every and anything.
Right, but the every and anything doesn't necessarily give us more information. It's useful information, right? If I have, I mean, you know, Gleason 10, do I need an epigenetic test to tell me that that's going to behave very aggressively and potentially go, you know, go to the lymph nodes, go to the bone, et cetera, et cetera? Is it going to alter my management? My first line of management is still going to be ADT therapy. And when that rises, then I'm going to, you know, do stuff like Xtandi or Zytiga or one of those, or Erleada. And then if that ends, then maybe, you know, chemotherapy or Provent or something like that.
I'm just joking.
Yeah, so my point there is when you're kind of earlier in that advanced cascade, it's not going to alter your management whether you know that information going forward, because now you're already in the advanced prostate cancer space. Where it's important is in either the localized or the local regional prostate cancer space, right? I had a guy that I did a prostatectomy on. He had Gleason 9 prostate cancer, PSA of only 11. I mean, I say only 11, but you know, Gleason 9, I would expect it to be real high. They took his prostate out, negative margins, I got everything out. He did have some extra prostatic extension, but I got it all out. His final pathology showed Gleason 4+3. First of all, I don't know how it downgraded from 5+4 to 4+3, but he had 2 lymph nodes positive. So the pathology looked like 4+3, but it behaved biologically like a 5+4. You see what I'm saying? So I sent a Decipher on that gentleman just to get a baseline of what the likelihood of doing adjuvant radiation in that setting would be. Because I can, if it shows that he's at a higher risk, and I can post-prostatectomy-wise get his PSA down to undetectable levels, I'm definitely going to recommend radiation in him to get whatever's left to keep him in remission for Gleason 9 prostate cancer. So I would consider that a win, you know? Because we've removed the prostate with curative intent in the first place. Now I really want to make sure, does he need any further treatment or not?
The Decipher, so there's 2 parts of the Decipher score. There's the score itself and then what they call grid.
Yes.
Well, the grid provides some more, not only data, but also some advice or recommendations about treatment. Mm-hmm. Like it may say, well, your cancer looks like it may not respond to ADT, or it may not respond that well to radiation.
Right.
Well, what kind of value do you put on the grid?
I personally don't put a lot unless we're in the process of having those discussions. Okay, so let's say I have a guy whose PSA is undetectable for a year or 2, and I sent a Decipher on him a couple of years ago. Technically, it shouldn't really change. The data shouldn't change. Now, 2 years later, I see his PSA has gone from undetectable 0.1 to 0.2, and now it's 0.3. And I'm trying to figure out whether radiation is going to benefit him, or I'm trying to figure out, should I radiate the prostate bed and the lymph nodes, or just the prostate bed? Does it look like possibly it's gone? So that's when I'll call the manufacturer and say, hey, can you run the grid for me and give me that information so that I can look at that. And so when I counsel him, I can say, hey, look, yes, this data is new, but in looking back a couple years ago, your prostate cancer suggests that adjuvant radiation, so adding radiation to surgery, whether it's immediate or it's salvage, meaning once the PSA starts to rise, can help you. Then I give it to him, right? Or at least talk to him about it. It's not a perfect science yet though, right? The grid it's information that's being collected, and probably my idea is that they're probably going to use that information, not patient information, but use that global information to figure out trends and correlations and basically map out future studies. Because the next thing is just like we say 5-year metastatic risk, mortality risk, we may see things that say ADT will or won't work, radiation will or won't work. They're already doing it for bladder cancer. So Decipher made a bladder cancer test, and they're showing based on, is it a basal type, is it a luminal type, cell type expression, that can predict whether patients will do better with chemotherapy before you get your bladder out, or whether you should just go straight to surgery. I mean, that's remarkable, right? That data is unbelievable. Prostate cancer is a biologically different type of cancer, but I think that's what that grid is going to be used for. Yes, sir.
I'm going to start big. Okay, let's say a year and a half out, you start with 0 PSA after surgery, but it slowly starts to increase 0.01, 0.02, 0.03, and your Gleason score going into surgery is up at Gleason 8, Gleason 9. At what point after surgery, when that PSA starts to rise, do you want it to get to 0.1 or 0.2?
The strictest.
Before you get there, if you have a Decipher that says, 5 years out, you have a fairly high risk of.
Yeah. So after surgery, we call, depending on what criteria you use, biochemical recurrence. What that means is you don't have a prostate, so we can't necessarily see prostate cancer.
Right.
But biologically, you're seeing evidence of prostate cancer cells, because again, the only thing that would produce it would be prostate cancer cells when you don't have a prostate, especially when it went to 0 for so long and then it started going. 0.2 or 0.4 is what we call biochemical recurrence.
So 0.2 would be a reasonable point?
Yes. Yeah, 0.2 is kind of the stricter criteria, 0.4. After radiation, we have criteria called the Phoenix criteria, which was made by a group called RADAR, which is a radiation, I can't even remember, that's where I need Dr. Geyer here. But the idea there is 3 subsequent rises in the PSA after it naters after radiation, so after it hits the lowest point, 3 subsequent rises, or if that PSA rises above 2.
Above what?
2.
So how long?
That's after radiation.
How long of a time would you expect that to take to get to?
Oh, it's different so that's part of the nomograms that we do before surgery. So when I see patients before, like when they first walk in my office and we've diagnosed them with prostate cancer, and I've done the biopsy and we're sitting there talking about it, I show them what's called the Han nomograms. It's data that's collected, I believe at Johns Hopkins, kind of like the Parton tables. But these Han nomograms will tell you what is the chance of biochemical recurrence at 3 years, 5 years, 7 years, and 10 years. In all honesty, when I counsel patients, I don't really care about the 3 year, 5 year, 7 year data. I'm looking at the 10-year data, right? Unless you're like 80 years old. But if you're anyone else, anyone younger, I want to look at that 10-year data, and it will say chances of biochemical recurrence after prostatectomy based on your Gleason score, your PSA, your prostate exam is 94%. So for most Gleason 6s, it's usually in the 90s. For Gleason scores of 7, it's usually in the 80s. And then for Gleason scores of 8, for instance, in your example, it may be in the 50s to 60s.
So what if you are 80? Then what?
If you are 80?
Yeah.
Depends on how fast that PSA is rising and what that doubling time is. If you are going 0.1, 3 months later 0.1, 3 months later 0.1, 3 months later 0.2, 0.2, 0.2, 0.2, 0.2, 0.3, 0.3, 0.3, 0.4, it's an indolent recurrence of cancer. It's a slow recurrence. It's probably not biologically acting as aggressive as your original Gleason 9 would suggest. But if you're going from, in a 6-month period, if you're going from undetectable to 0.1, and then the next 6-month period you're going from 0.1 to 0.2, and the next 6-month period you're going from 0.2 to 0.4, that's when I'm going to get it. because now your doubling time is 6 months, and we know that doubling times, really in the data, they either say 6 months or 9 months, has a much higher chance of cancer death from prostate cancer. So that would be, if that were the case, I would go ahead and call you in and say, hey look, PSA is up to 0.4, let's go ahead and do a CAT scan, bone scan, just to make sure that nothing's lighting up in the lymph nodes or the bone. And this is all with the presumption that after your prostatectomy, nothing was there in the first place. And then if those are negative, I'd give you radiation right off the bat.
If it's 0.01, 0.02,
0.0, there's going to be, you know, those are different lab assays. 0.01, 0.02 are 0. If you look at our lab assay at most of the hospitals around here, like either Christ, UC, etc., they're only reporting less than 0.1 as undetectable, right? So you could have 0.009 and it's going to still show up as less than 0.09 and it's going to be less than 0.1.
Okay.
So clinically significant is 0.2 or 0.4.
Okay, so 0.1 or less is your 0 point.
What's that?
Less than 0.1.
Is 0 point. Yes. That's what we would call remission in a sense.
Okay.
Yes, sir.
I
Sorry.
understand you do robotic.
Yes.
How does your robotic system, how is it like the one that Urology group?
Yes. So we use a Da Vinci robot system. So what it basically is, and I'm sure some of y'all are familiar with it, but it's very similar. So we have, you may have heard of, you know, laparoscopic surgery, like taking a gallbladder out or taking your appendix out, where you put a camera in the middle, fill the belly up with air, get that camera in, put other trocars in there. Then we connect it to a robotic device, which is basically laparoscopic arms that the machine is clipped into. And then I'm on a console on the side with a three-dimensional viewfinder. And the difference between robotic and laparoscopic is only, it's like this. It's very difficult to tie because you can't have 360 degrees motion. Whereas robotically, when I'm rotating my wrist like this to throw a stitch, or I'm doing this, it's doing the same thing with my instrument in the body. So it's a lot finer detail, less risk of blood loss, less risk of lower hospital stay, overall less cost from all prostate cancer related issues, incontinence, ED, all that stuff, because you can further see the nerves. And you walk out of there with 6 small incisions about this big. One of them we got to make a little bit bigger to get the prostate specimen out, but they're all about that big.
So is that all you do is robotic then?
No. I do robotic surgeries, open surgeries. I don't do perineal prostatectomies. I do brachytherapy, so I do seed implants with Dr. Geyer. I put in the fiducial markers for radiation with Dr. Geyer. Okay, so when you guys come in as a prostate cancer patient for your discussion, I'm going to be part of any and all treatments, right? Whether it's me putting in the fiducials, me helping put in the Cs, or me removing the prostate. I'm going to be part of all that. So from my standpoint, I'm not just going to be like, oh, I'm a surgeon, you need to have surgery, because I'm doing those other things with Dr. Geyer as well, which is the important part of our collaborative effort.
So do you do much seeding anymore, or is that?
Mm-hmm. Yeah. Usually we'll do it for low volume, smaller prostate, Gleason's 6 or 7, as monotherapy, where that's all you get. We're also doing it in high-risk patients, so Gleason 8s, 9s, or 10s, where they've had external beam radiation with a boost of seeds. Okay?
Yeah.
So those are the patients that are getting brachytherapy. It's almost the two spectrums of curable prostate cancer, the low-risk guy or the high-risk guy. Yeah. That's either not a surgical candidate or has had multiple operations on the abdomen or has previously had radiation on the abdomen for colon cancer or something else, or a bowel resection where surgery is probably not the best course of action with that high-risk cancer. That's where we're doing radiation with a boost of seeds. So, but you can't do seeds when the prostate's too small,
right.
And you can't do it when the prostate's too big or you're having a lot of symptoms from just enlargement of the prostate.
So why would you do open surgery now with Da Vinci?
Lymph node dissection. Oh, if for whatever reason there's a lot of adhesions in the abdomen and the pelvis, the last thing we want to do is stick a needle in there and now all of a sudden we hit the bowel. So if there's a lot of adhesions down there, then we'll do an open. And it gives us the ability to do a lymph node dissection. Open, we're doing very rarely now. There's, we'll do it if we need to do it, but when you look at the risks of an open versus robotic surgery, or the risks of open surgery versus radiation, usually if we're not going to do a big open surgery and keep you in the hospital for 5 days, we'll offer radiation if you're a candidate for radiation.
So what do you do about the lymph system then when you're doing robotic?
We do a full lymph node dissection.
Oh, you go ahead and do it?
Yeah, so if your preoperative data suggests that there's at least a 2% risk of lymph node metastatic risk, we do the lymph nodes right then and there. It takes an extra 10-15 minutes on both sides.
Okay.
Doesn't add much morbidity to the operation, and it's as much diagnostic as it is staging. We're not only figuring out if it's there, but we're using that information to figure out what your stage of prostate cancer is, right?
What is the risk factors pre-existing for surgery that would have you do the lymph nodes?
Risk factors are usually, and I'm going to break it down real basic. Usually if you're an intermediate risk prostate cancer, so if you have Gleason 7 or you have a PSA above 10, again, this is or, okay, this isn't and, it's an or. Or if I do an exam on you and I felt a real firm prostate, and at least half of your prostate, and one side is real soft and smooth, and the other side is just rock hard, I say, look, something's probably going on. Let's just make sure that the lymph nodes are negative. So that's one thing. Gleason 6s, the likelihood of finding anything there is 0 to 1%. In data spanning 20,000 patients in the Johns Hopkins data, I don't do it. But the flip side of that is I'm also not doing a whole lot of prostatectomies on Gleason 6 patients anymore. Right? I'm doing one here and there. Usually it's a 7, 8, or 9.
How many 6s turn out to be 7s once you...
20 to 30%. Yeah, the upstaging of 6s to 7s is about 20 to 30%, and that's where the Decipher test is helpful. Because biologically, you might see something that behaves a little more aggressive than a Gleason 6, even though there could be some sampling error on the biopsy that just showed Gleason 3 patterns, so the 6, but there may be a little bit of force somewhere in there that's being reflected on the PSA or the genetics of that test.
Yeah. This is just curiosity, but when you do it robotically, what guides you? Is it just a TB camera, or do you use an MRI, brought to the surgical table,
visual,
or ultrasound, or?
It's visual. Yeah, so just like just like if you were doing a bowel resection, or you were taking, your pancreas out, or your gallbladder out, it's all visual. We have visual landmarks. We have very methodical ways of going step to step to step to step.
It's all based on a laparoscopic camera, so it's actually just...
Yeah, but in laparoscopy, it's a two-dimensional image you're looking at on the screen. In robotics, because it's binocular, you're looking in three-dimensional. I'm seeing things three-dimensional.
So you actually put in two cameras then?
Yeah, it's one camera with bifocal, or not bifocal, with binocular lenses.
Oh.
So you're actually able to see in 3 dimensions. So I can judge depth with my instrument. Now what you can't judge on the robots right now is what we call haptic feedback, which means
if you touch
tension.
Hard, it touches you.
When I'm tightening a stitch, I'm looking at tension, I'm not feeling tension. It's not going, if I just hit my arm on it and it does this, it might fly off and break the stitch, but I didn't feel any tension on there. So you have to look at tension and not pull it and feel like you're going to feel tension. Yeah. So it's very micro, it's very small maneuvers. We're not like
you're saying, I thought haptic was that as you're pulling on it, you'll actually feel it in your
hand.
Right,
so there's no haptic feedback.
Oh.
So that would be haptic feedback.
Oh, I thought you said you
if I pulled on it, I could feel that resistance The robots we have now do not have haptic feedback. Yeah.
Mark Bell was going to host us in May, we think,
Oh, good.
up at B North, we're
Yeah.
actually using machines.
Oh man, I'm sorry that I'm following Mark Delworth. That guy's super busy.
We quit at 9 o'clock. Did you want to say something?
No, I talked about the second thing
You're okay, all right.
beginning, so.
So, yeah.
Well, I cast my lot with the urology group, because what do I know? I mean, it's where your GP sent me, and I seem to be doing all right there. But hearing you talk, I would sound, I'd be very confident in your abilities too. But is there an interaction? In other words, does the urology group ever send patients over to you, or do they try to do it all in-house?
Probably not.
No, they try to do it all in-house.
No, sure.
I'll be very candid, very honest with you. They try to do it all in-house because they're, the big show, right?
But you guys do the same. You don't send patients away either, right?
No. But every now and then we'll get patients that, in a sense, kind of defect from the urology group. I'm sure we probably have some patients that defect from us.
Yeah.
I always offer second opinions from whoever you want to. For instance, if it's urgent. I mean, that's some patients that I've done prostatectomies on are guys that have gone to the urology group and they wanted a second opinion and they just felt more comfortable with me and I did their prostatectomy.
I find it interesting the words I chose, though. This is Lent right now.
Yeah.
I said I cast my lots.
Yeah, exactly. No, but I mean, as long as you have a good urologist that's staying on top of things and staying up to the literature, staying up with the literature, and which is changing daily, literally daily, then you're fine. The worst thing you want to do is, go to your urologist that's like, oh, well, let's just give you a hormone injection and check a PSA once a year. I don't know if that's the right thing. You probably want to get it checked at least every 6 months. I would make a case for checking PSAs every 3 months. The reason being, any advanced prostate cancer, 3 to 6 months I'd say, any advanced prostate cancer overall survival advantage is 4 to 6 months. So if I have you check a PSA and I see you in 6 months, and let's say that was when something bad happened to you, I've missed it already. You see what I'm saying?
Oh, exactly.
Because people the oncology world went crazy when we found Taxotere extended survival by 4 months, right? Which on the surface you're like, that's nothing, but that was groundbreaking in survival advantage. When you're talking about patients that have already had surgery and then radiation, now they're on hormones, now they've had extended, now they've had chemo, and it got them another 4 months, right? So it's changing all the time. There's there's something like 20 different medicines that are being tested right now in different parts. There's existing medications that are now being worked in an earlier, trying to give the medicines earlier, like indications earlier. For instance, if you're on hormone deprivation and all of a sudden your PSA starts to rise again, going ahead and getting Xtandi, where historically, as of 6 months ago, you had to wait until you got a CAT scan or a bone scan that actually showed metastatic disease. Then only would insurance pay for it. Now they're paying for it earlier because it has those indications.
We did have a doctor in here who was promoting Provenge early rather than late stage.
Yeah, if you have castration-resistant prostate cancer, I give Provenge it's a one and done. You get your month treatment course, it's working in the background, it's an immune medication, while I'm giving you Xtandi or Zytiga. Or actually it's Xtandi or
all at the same time.
Yeah, so because they have completely different mechanisms of actions.
Withdrawal.
Provenge is a one and done, so you're going ahead and getting that, and it's always in you. It's having your own immune system fight prostate cancer.
What's that called? Provenge?
Provenge.
V-A-N-N or?
No,
Provenge. But it's only for castration-resistant prostate cancer that's minimally symptomatic or asymptomatic. So you can't be taking like narcotic pain medicine for back pain and stuff like that. And then I would give Xtandi. So it's kind of a one and done, but also your maintenance medication is one of these other advanced drugs.
So the combination might be very positive?
Yeah, and I don't even see it as combination because Provenge you're only doing for a month and you're never going to get it again. It's just like, it's almost like a cycle. Think about it like a cycle of immunotherapy or one cycle of chemo.
Yeah, it's withdrawal, right?
And you're done with it. You never get it again because getting your own cells to fight prostate cancer cells.
Yeah.
So
That's interesting.
Yeah.
To do it early.
yeah, I do it early. If someone has a rising PSA, but you have to find metastatic disease.
Right.
So they have to have either bone mets or changes on radiography, like on a CAT scan, you find something, or on a bone scan, you find something before it can be given. You can't just say, oh, their PSA is rising, I'm going to give Provenge. It has to be with someone that has some progression. Or the guy who you initially diagnosed with metastatic disease that you started on ADT to just keep everything down, and now all of a sudden the PSA is rising, then I give Provenge
And a combination.
yeah.
Why don't we break now in case some of the guys want to talk to you privately?
Absolutely.
Just give them a nice hand.